Guam's current COVID case count is now 3,886. People that have been infected with coronavirus since March, 1,466 people are actively fighting the virus, while more than 2,300 have recovered. There have been 67 COVID related deaths. As for hospitalizations, 59 COVID patients are hospitalized at GMH, 13 are in ICU or receiving ICU level of care, 5 are on ventilators. At GRMC, there are 7 COVID patients hospitalized there, with 1 in ICU. At Naval Hospital, there are 4 hospitalized there, 3 in ICU, and 1 patient on a ventilator. Again, that is at Naval Hospital.
And let's go ahead and bring on Dr. Annette David. Greg gave a really just so insightful presentation. There's been so much clamoring for data, Doc, for statistics, for breakdowns. Not
what
just
do the numbers mean?
right.
So.
And so your presentation, I mean, just wow, we were so impressed. Not just with the data and the information you presented, but the way you presented it as well. So. We just wanted to give you props on that. Could we just start maybe with your take on these numbers, right? I mean, you crunched the data. You've seen it firsthand. It's been in your face. 130 positives last night. Hospitalizations, climbing, deaths just keep coming.
Mm-hmm. And also the results from the rapid engagement testing and how it compares to the analysis that you provided during last week's press conference.
Well, first of all, thank you for inviting me on the show. I think, data is important, but it's important to get the data right. And so a big question I think that we always have to ask is, when we're just looking at absolute numbers, is what do they mean, right? By themselves, absolute numbers may not be as useful. So it's always important to look at the number of positives every day, but always to look at that in comparison to the number of tests taken. So there's always a denominator. And so yesterday, the 130 who tested positive out of the 957, that's a 13.5% positivity rate. And to me, that rate, that's very worrisome, because that means that more than 1 out of 10 samples that's getting tested is positive. And that's an indicator of the magnitude of how widespread the virus is in the community. So I think it's always important to look at it as a rate rather than as an absolute number. I am worried.
Doc, when you talk about these numbers, the number of positives, the test positivity rate, being an indicator of how widespread the virus is in the community. Can you tell us about the picture we're not seeing? What these numbers are not showing? Just how widespread do you believe the virus is?
That's a really good question. Well, these are the numbers for those who are tested, right? But majority of folks in Guam haven't been tested. So this is just a marker, but we don't really know how widespread the virus is in the community. And to be able to figure that out, we would have to expand testing considerably. And that's the thing, right? A lot of that depends on our capacity to test and how many tests are made available to us. I think the bottom line is this virus is highly infectious, and the numbers are telling us we need to do more to stop transmission.
What, in your opinion, do we need to do more of?
Well, it's not that difficult, right? At this point in time, all we really have to counter the virus is prevent transmission. We don't have a vaccine. We don't have medical treatments if you get sick. So really, our biggest weapon here is to prevent the transmission from happening. And we know what the data and evidence says works. It's staying at home unless you really have to go out. It's physical distance, wearing the mask, and hand hygiene. And so if we're able to implement those simple things universally, then we can make an impact. At the end of the day, it really depends on how well each and every one on Guam implements these measures.
that being said, I mean, look at the numbers. They don't lie. I think do you believe they show that people aren't implementing those measures?
Yes, clearly transmission is happening. So there's a break in the preventive measures somewhere along the way. And that's really what the numbers are telling us. I mean, a virus it's not even a living being. It's not a completely alive thing. But the virus is programmed to do one thing. It's programmed to look for a host because a virus can't live outside of a host. And so this little thing that we're up against, it is constantly searching to find the next host so it can propagate itself. Now, it doesn't have legs, it can't run or walk to the next host, and it doesn't have wings, it can't fly to the next host. So it's the host's behavior that determines if the virus continues to propagate.
Doc, you presented last week at the press conference, and maybe we could just now go into the data you presented based on the different ethnic groups, right?
Right.
I felt that the data you presented, and you kind of broke it down where I remember the number 2 group in terms of infection rate was the Caucasians, and I think some military. The top one, though, was Chukis. Was that just specifically Chukis or Chukis / FSM descent?
Well, the way the numbers played out in terms of the risk for infection, the Chukis had the highest risk, followed by other Micronesians and then Caucasians. But I think it's important to really emphasize that it's not the race itself. It's not one's ethnicity that puts you at risk, but that really ethnicity is more a marker for other things like what your occupation is or like what is the overall health status within your group. So I think that's important to emphasize. And what the numbers are saying in terms of transmission are that these 3 groups are at the highest risk. But when you look at who's at risk of dying, then it changes a little bit because the Chukis and other Micronesians still have a very high risk of dying, but it's the Filipinos who come in third. So a slightly different picture there.
Right.
Can you explain why that's that way?
Well, if you think about it, what puts you at risk of death from COVID-19? It's really your health status, right? So that means if you have things like obesity or uncontrolled diabetes or uncontrolled hypertension, these are the comorbid conditions that put you at higher risk of mortality. And so if you have a population that has a higher risk of these comorbidities, then they would be more vulnerable. And I think that's what we're seeing. I think on one hand, people are afraid to go for their regular medical care because of the virus. And so what's happening is they're maybe not getting as much medical supervision for their diabetes or their hypertension or their cancer, or putting off treatments or putting off going to the doctor. But that paradoxically, that puts you at high risk of severe COVID if you get it. And then also, I think very importantly, is access to care, because one major determinant of why people would go to the doctor to control an underlying disease is, do they have insurance, right? And so many people have lost their work during this pandemic. And, when you lose your job, many times that there's your insurance, it's gone. So, people have lost access to care. And so these are the things that I think the numbers are pointing us to direct some efforts towards these issues.
Right. So the data that you presented, it sounds as though it was sort of like the impetus behind this rapid engagement team's deployment to the Gilbaza and the Zero Down subdivisions. Are you also going to be part of the team that's going to be analyzing the data?
I'm really a volunteer at this point in time, and I'm always happy to help. And I am working with Director Art and the public health folks with the data. So yes, I think I will be part of that. But like I said at the presentation, at this point in time, the virus is pretty widespread, and the question is, should we start thinking about more proactive case finding rather than just waiting for people to present and test positive
Right.
and then trying to find
Yeah.
their contacts.
Doc,
Yeah.
so when you presented this data and then we deployed the rapid engagement team and they shook the tree at those subdivisions and it rained down positives, were you surprised at all or?
Um, no, I think it confirmed what the data showed, and really a big part of that is the environmental and the social determinants that put people at risk. So one of the issues is, when you have very high densities in your homes, it may be that everyone's staying at home, but the person going out to work gets infected from work, and when they come home, because you can't effectively isolate, then everyone else gets infected, and that's how it propagates to the community. So I think the active case finding is going to be crucial for us to be able to control the virus, control the pandemic in our community.
So we know how to do the active case finding in the with the ethnic group that you said had the highest risk of infection. What about the second highest group, the Caucasians? How do we do active case finding with the white folks?
Well, I think, well, first of all, I think case finding, we probably shouldn't limit it. Again, it's not your ethnicity that puts you at risk.
Yeah.
The conditions, So ethnicity is just some sort of marker of higher risk.
Right.
I think for our Caucasian population, the interesting thing is that while they are at higher risk for transmission, they're not at high risk for mortality. So very likely these are younger, these are healthier folks who get the infection but are asymptomatic or have very mild disease.
We have a comment here in our Facebook stream, Doc. What would Dr. David's recommendation be now that the first rapid testing deployment is completed?
I think we need to do more. I mean, ideally, you want to be testing widely. And really, if you think about it, look at New York. What enabled them to get a handle on the pandemic there was very widespread testing and quick identification of cases and isolation of the cases. So you're basically cutting that transmission. And I think for Guam, we have to strive to be able to do that, especially because we do want to start getting back on our feet economically. And widespread testing is going to be a cornerstone for us to be able to achieve that.
Are you part of the Physicians Advisory Group?
No.
You should be.
What happened? You seem like it would be a no-brainer to have you on there. Did you make somebody mad, Doc?
I don't know. You know how it is, right?
Okay. It is what it is.
No. But well, it's this has been also a very challenging time for me personally, health-wise.
Okay.
I was volunteering early on with public health. In fact, I helped to set up the isolation facility, but I was diagnosed with skin cancer in April and had to have surgery in May. So that kind of had me to step back a bit.
Right.
And then my husband broke his arm last month.
Right.
His right arm.
Wow.
So it's been a little crazy for us health-wise, but you do what you can, right?
Yeah.
So
Well, let me ask you this, Doc, because we do get the doctors from the Physicians Advisory Group on, I mean, all the time, and so we've had Dr. Wen on, and at least for the past month, he's been talking about this idea that we can't move backwards, that we've set into place allowances under this PCOR 1 designation. That kind of makes it seem like it's not really a PCOR 1 designation. And as we've eased these restrictions and allowed places to open at whatever capacity, wide swath of different types of businesses and services that we can now go and go to and spend money at and all that. While that's running, we've seen the numbers increasing steadily. We've seen the deaths increasing steadily. And so when Dr. Wen comes on and says, we can't move backwards, he means we can't lock things down in a real PCOR 1 fashion. What do you make of that? And do you think that having all these options available to us during this PCOR 1 lockdown is contributing to the spread? Would it be prudent to maybe roll some of them back, in your opinion?
Well, let me give you a public health perspective on that, right? I mean, a lockdown is really intended for us to buy us time so that we can prepare. But in reality, a lockdown is not sustainable. You can't keep that going forever. And so you really have to start planning ahead. And I think one important thing for our community is a mindset change, right? I think many of us are still hanging to the hope that this virus will be gone by Thanksgiving or by Christmas. But I think we have to prepare ourselves mentally and psychologically that this thing is going to be around for quite some time, and I think maybe well into next year. So once you start to accept that, you can start thinking about what are the things you have to put in place so that you can start building back towards a more normal life and return to some form of normalcy for the economy. And there are certain things that have to just be in place, right? You can't have super spreader events. So you can't have stuff. You can't have events like big weddings or big parties. You can't have that. You have to have universal mask wearing. So if we ever get to a point where we want to open businesses, it's got to be very clear. Everyone has to wear their mask. And you've got to wear the mask all the time. Because the reason why there's a break is when people take the masks off in like the lunchroom or when they're hanging out with their friends outdoors, you got to wear it all the time and you've got to wear it right. How many times have you seen folks and they're wearing the mask, but the mask is here and the nose is out? That doesn't work. You've got to cover your nose and your mouth. So that's got to be an important precondition. You have to have the physical distancing and the hygiene and the sanitation and all that. I think a good thing to think about is maybe every business, every school, every restaurant has to have somebody who's trained in contact tracing in-house, so that if someone in the staff gets positive, that you can begin the contact tracing already from within your own institution. And there's online courses and UOG offering to do the training for that. So maybe that's something to think about. If we want to open, businesses have to have somebody in-house who's trained to do contact tracing. And then, of course, the widespread education and outreach and advocacy. Mm-hmm. But I think we need to accept the fact that this virus is going to be here and that maybe life will never go back to the way it was before the virus came. Right. And I think once we're over that psychological hurdle, we can start thinking about how we move forward.
Dr. David, did you say you help with the standing up of the isolation facilities or providing a...
Yes, back in March at the beginning, yes, we created that.
There was a hearing last night, discussions about the COVID isolation processes. Did you get a chance to see that by any chance?
No. After I had my diagnosis, I'm afraid I wasn't able to keep up anymore. So I don't really know what the status is at this point.
Yeah, it was pretty interesting because they were talking about the differences in terms of the monitoring for the people that were on home isolation versus those that were in the government isolation facilities. And the ones that are in the government isolation facilities are more of the younger people. They don't want to be at home because the people at home are the ones with the comorbidities. Then you have the ones that are in home isolation are the ones that have the comorbidities. And so they get the twice a day type phone calls. And so then the discussion became like, we should maybe think about opening a COVID clinic for these people that are on home isolation. To check in daily, basically, so that, doctors aren't just like, okay, well, you have COVID, go home. And then if you can't breathe or you have a hard time breathing, go to the doctor. Do you have any thoughts on the opening of a COVID clinic?
Well, I think if someone's in home isolation, you don't really want them going out in public. So, with telemedicine being available and, everyone on Zoom basically the entire day, I think it's possible to set up a system where if they have any medical issues that they can get hold of a healthcare professional without having to leave their home. So the point of isolation is you have to stay put. You don't really want to go out at any point in time where you can transmit the virus. So technology, I think, will enable us to address that. But I like where you're going, which is that it's important to have in place some sort of medical safety net for folks who are COVID positive and may have pre-existing conditions. Yeah.
Man, you need to, man, if you have time, you should try and get in on this physician advisory group.
Or never mind, you could just come on the show every week.
Yeah, just come on.
Right in, candidate.
Yeah. Doc, I know you're giving a presentation on vaping and COVID this afternoon.
It's on today at lunchtime, so join in if you have the time.
Well, I'm just maybe you spoiler alert, guys. Can you give us a little preview? Because we've talked to different doctors who, obviously, at the onset of the pandemic, a lot of it's a respiratory disease that affects the lungs. We now know that it also affects other systems within the body. So, give us an idea specifically with your discussion, and for the people out here vaping their lives away, how risky is it?
Okay, well, I'm not even going to get to that point of lung disease and all. I'm going to be very, very practical, right? Your biggest protection against the COVID virus is your mask, right? Well, when you vape or you smoke, you have to take off your mask, correct? So with that alone, you already open yourself up to infection. And then when you vape or you smoke, the hand to mouth is very frequent, right? And one of the risk factors is transmitting from your hand to any of your mucous membranes. So the hand to mouth activity puts you at even higher risk. And then the third thing I'm going to share is, when you think about the virus can live on surfaces for quite some time, right? And what they found is on cardboard and paper, it can survive for 24 hours. And on plastic and metal, it can survive for up to 3 days. Well, what's your cigarette made of? It's made of paper. So if someone's virus has been floating in the air and has somehow landed on your cigarette, it can stay there for 24 hours. And on your vape device is made of plastic and metal. So again, these devices you can put down on surfaces, and then you put it back in your pocket and you take it out and you bring it back in. And if there's a virus on that, it could be there for 3 days. It could be hanging around quite a bit. So just from those very practical points, already you have made yourself vulnerable to infection. And there's a little bit more that we'll go into later.
I'm sure.
But I don't want to
just a little Chessa, right? Just a little Chessa for us. Doc, we had a comment here from Bobby Beneventi. What's up, Bobby? Asked Dr. David to come back and speak about Guam suicide data that she has led in the collection, analysis, and reporting for over the past 10 years. That sounds great, but the thing is, I know you're so busy, so maybe if you could just kind of address that now, because people have said that it's alarming, the number of suicides that have happened during this pandemic. You've seen the numbers. Is there an increase because of this pandemic?
Well, the numbers we have in Guam are very small. So we tend to aggregate everything in an annual sum before we do any sorts of analysis, because if you have very small numbers, then your analysis may not be very accurate. But I will say this, we are thinking of COVID-19 as a standalone illness, but in fact it's not. It is a collision of a number of epidemics that we're seeing now. It's a collision with the non-communicable diseases like the hypertension and the diabetes, but there's also the mental health issues that we have to consider when it comes to this pandemic. You know what? We're all going to come out of this with post-traumatic stress, right? Because everyone is under so much tension, so much like emotional grief because of this pandemic. It's broken up families. You can't see for Thanksgiving, are we going to see our grandkids on Thanksgiving? People are afraid of the insecurity because of the employment status. Will I lose my job? Mm-hmm. So there's a lot of mental health issues, and certainly that would put you at risk for suicide. So it's very important not to forget all of these other health issues, mental health issues that really are exacerbated by the conditions we're living in right now. And I'd be happy to come back at some other point to talk about suicide, because it remains an urgent public health issue in Guam.
Thank you.
Thank you so much, Dr. David. I don't want to let you go. I mean, what else can we talk about?
I can always always come back.
Okay,
you know
okay.
Please go back.
Right. Thank you. And we're going to get Lillian on next to catch us up on the hospital. So thank you again, Dr. David, for your time. Keep in touch. You got my email. I'll shoot you my cell. So if anything, any insight you want to provide, it's always good. The more voices, the merrier.
Absolutely. And you all stay safe.
You too, Doc. You too.
Thanks.
God bless you. Wash your hands. And all we have in our KUAM News Zoom room, we have virtual ship biscuits, the Navy biscuits. We've also got some virtual masubi. There is a vegan one if you're watching your diet, Doc. Okay, so we're going to take just a really quick break. The lineup, we've got Dr. Michael the Physicians Advisory Group Education Committee Chair. We've got Christine Faharan to talk about Arbor Month with the Department of Agriculture.